Hey everyone, today I will be discussing very basic topic that bothers us much, which can tell us much about patients, heart condition and vessel conditions. We will be approaching pulse and understanding its variants. Pulse is a performance of left ventricle ejection and it tells us about the pressure wave which originates in the aorta due to the left ventricle systole. This is the left ventricle that is ejecting. So it is the left ventricle which is ejecting into the aorta, and that gives us the pulse, which travels in 5 meter per second, and the column of the blood is 50 centimeter per second. This is the pulse that is normally seen. So this is a percussion wave which we are feeling while palpating a radial artery or any of the artery. Then this is the tidal wave. This is the dicrotic wave and a dicrotic notch. These are the four components of that of a pulse. So we need to understand that the percussion wave and the S1 they both collide with each other, and the dicrotic notch, okay, it is the S2 just comes after that of the dicrotic notch. Now, this the two important variants of the that of the left ventricle. These are the stroke volume and the ejection velocity. Very important in determining the pulse. So, if the stroke volume is of high amplitude, naturally the blood is ejected at a higher velocity, and much of the blood and much of the cardiac output has been ejected out. So, it will have a high amplitude. Okay, peak, and this is really important for us to know the heart condition, like in if the patient is having a hyperkinetic situation like that of a anemia, if that of a very like that, and the patient is having MR, so we need to confirm it with the pulse, and the patient should be treated accordingly. Like if it is a hypokinetic, let us in case of any of the shock condition, we need to treat it, we need to see for the cause, and we can also start the patient on the inotropy that we are doing in our wards. So coming to a percussion wave, so it is nothing but it is a left ventricle ejection systole. That is the velocity of the ejection. Okay, and it is a stroke volume. Okay, so now this is very important. Okay, while palpating the pulse, we see for the percussion, hmm, which is we see for the percussion wave. Okay, so whenever I am putting a hand on my patient, so it is the percussion wave that is I am seeing or I want to feel. Then comes the tidal wave. This tidal wave is nothing but it gives us the information about the elastic recoil of the aorta. Now, this is not seen in a normal individual. Then coming to a dicrotic wave. Now, dicrotic wave is giving us the peripheral resistance. So it is the peripheral resistance that is seen. The more the peripheral resistance, the more would be the peak and the more would be the wave. And the notch that corresponds to S2. So how do we palpate the pulse? So the character and the contour, which is best felt at the carotids. Okay, C for C. Remember, hmm? It is seen in a supine position, ideal with the neck slightly turned to the side of the palpation, and auscultation has to be done simultaneously. So to know whether the patient is in S1 or S2, the wave whatever we are feeling. So the pressure wave depends upon the compliance of the aorta, the velocity of ejection, and the left ventricular pump. I have been stressing on this left ventricle and the stroke volume and the cardiac output because these are the important determinants. The pulse wave velocity, whenever there is increase in the systolic volume, stroke volume, so there is a velocity of ejection is also increasing, and that is actually a peak which is achieved earlier. Now, if we consider a patient whose vessel is absolutely normal, so this is the pulse that would be uh, going, okay, and it is also going to the walls. So these walls will actually absorb some of it. And there is the pulse wave velocity is normal, or it is it not high, okay. But in case of patients with atherosclerosis, there would be atrial aging, and that will lead to the loss of cushioning effect, and there will be increase in the pulse wave velocity. So now it is in the definition of hypertension, it is the pulse wave velocity which is the determinant. So stiffness of the vessels is directly proportional to the pulse wave velocity, and if the pulse wave velocity is increased, the cardiovascular events are also increased. The arterial stiffness increases, there is increase in the pulse wave velocity. So coming to the gold standard, which is important, is the arterial stiffness. Then, if the patient is having a compliant vessel, so the pulse wave velocity is low, that means it is reflected in diastole, okay, it will be coming at the later part. Then it is augment the diastolic pressure. Now diastolic pressure is important for the coronary perfusion, so it augments the diastolic pressure, so there is increase in the blood pressure, so that will lead to increase in the coronary perfusion. Coming to a stiffened vessel, what will happen whenever there is a pulse wave velocity? The peak will be achieved earlier, that is in case of systole, because there is no cushioning effect, and there will be increase in the systolic blood pressure, which will cause comparative decrease in the diastolic blood pressure, and there is coronary perfusion which is decreased, which is harmful. Then as we move from center to the periphery, so these are the certain pulses like aortic, carotid, brachial, radial, digital. So this is saying, this is giving us information about the dichrotic notch. Concentrate on the dichrotic notch now, which is giving us the idea about the peripheral resistance. Okay, now this resistance will be decreasing as the we move farther away from the main heart, right? Okay, main part. So there will be a notch which becomes smooth, and due to decrease in the resistance, it is occurring like that. And then we need to see in the pulse the radiofemoral delay or the radioradial delay. So this is normal delay for the pulse wave is in the brachial it is 60 milliseconds, in the radial it is 80, femoral it is 75, and carotid it is 30 milliseconds. Coming to the rate and the rhythm. Why do you have to see for the rate and the rhythm? So if the rate is say more than 100, we say it is a sinus tachycardia. If the rate is less than that of 60, it is a sinus bradycardia. Where do we see sinus tachycardia? Now, gone are the days where we say that it is a hyperkinetic situation, wherein there will be anemia, there will be beriberi, there will be hyperthermia. No, we should also tell the examiner other causes, so that he thinks that we know the concept very well. So the hypovolemia, like situation, any of the hypovolemia shock or cardiogenic shock or sepsis, right, and anemia and myocarditis, these are the things that you need to tell, and high output cardiac states, of course. Coming to the bradycardia, now very important, whenever there is a raised ICT, you need to tell it. RVM, and do not forget bradycardia is there, okay. Whenever there is a hypothyroidism state, myxedema, otherwise the patient has taken any of the beta blockers or calcium channel blockers, right, and hypothermia. Now, relative bradycardia, that means the patient should have increased the heart rate with increase in the temperature, but this is not occurring. So this is seen in mostly typhoid is the answer, but yes, there are other causes also. We need to see it. So if we consider it is a Faggot sign, if we consider if it is a generally 101 degree Fahrenheit, 100 per minute is the pulse, and with the 102, 110, with the 103, 120, with 104, it is 130. Okay, this the causes are typhoid, Legionella, Q fever, okay, and scrub typhus, and other infectious causes like that of CNS manifestations, meningitis, lesions, lymphoma, and drugs. Now we come to the rate, then we come to the regularity. Regularity, regular pulse is nothing but it is the SVT and VT. These are regular pulse. Coming to irregular pulse, AFib is the most common example, but other than that of the AFib, we have atrial tachycardia or atrial flutter with that of the heart blocks. This is also having irregularly irregular pulse, and irregularly irregular, that is in VPC. Okay, coming to the amplitude. So amplitude, that means the peak that will be responsible left ventricle ejection. Okay, that will be mostly in hyperkinetic situation, that will be more Hmm. So high volume pulse, hyperkinetic, low volume pulse, hypokinetic. So increase in the stroke volume, there is increase in the pulse volume. Hmm. Hyperkinetic pulse. So if we see for the dicrotic wave in the hyperkinetic pulse, the dicrotic wave in if we consider a hyperkinetic situation wherein left ventricle volume is more and there is decreased peripheral resistance. So what will happen to a dicrotic wave which is considered to be the peripheral resistance, which will tell us about the peripheral resistance? It will be low, it will be less prominent. Okay? In hyperkinetic pulse, as the peripheral resistance decrease, so there is increase in the stroke volume and cardiac output. There is decrease in the dicrotic wave, which is less prominent, of course, and a high volume pulse, but decrease in the cardiac output. Where is it seen? High volume pulse and decreased cardiac. That is in elderly individuals or in complete heart block. Hmm? Collapsing pulse. There is a word collapsing also, and there is a word which is called pseudo collapsing. Pseudo collapsing, that means it is seen where MR. Hmm? Collapsing pulse, there is a rapid upstroke, then there is insistent peak, okay, which is of high amplitude rapid upstroke, then it is a rapid downstroke. So this is high volume, high amplitude rapid upstroke, insistent peak, rapid downstroke, which is seen in AR and MR, and it is also seen in that of PDA, aortic sinus rupture. Then hypokinetic pulse, small amplitude, that is in LV dysfunction. What do we see in a aortic stenosis and aortic regurgitation? Aortic stenosis, there will be pulses parvus, right? And pulses parvus at tardus and pulses tardus. So what happens in AS is there is this hypertrophy which is has occurred. So the blood will try to pump much of the whatever blood is there. Okay, here is the stenosis. Hmm? So it will, the amplitude will be normal, but it will be a slow rising pulse. Okay? So there is a pressure hypertrophy. The ventricle work hard to pump the blood against the stenotic valve, and there is increase in the velocity of the blood. The jet of the blood, whenever we see a Bernoulli's phenomenon in this, that is, the pressure has been raised and the lateral pressure has decreased. Here the pressure is increased, the lateral pressure has been decreased. So that is the jet. Whenever there is increase in velocity of the blood, the jet of the blood, there is decrease in the lateral pressure. So that is giving us a slow rising pulse and the peak is delayed. So that is pulses tardus. Coming to a very severe AS, wherein there is left ventricle which is failed, it will not be able to pump. Okay, so what will happen? Amplitude is decreased. So amplitude is decreased, so there is low peak and it is a slow and wide. So that is called pulses parvus and tardus. So it is both of this is seen in AS. Then in severe MR, there will be a brisk upstroke, but this is will be of low amplitude. Okay, why is it so? Because the blood is there, okay, over here. It will try to pump, but there will be ejection which is occurring by the ventricle, and but it will not go. It will come back. It will go to the other side and it will come back like that. Okay, so that is a low amplitude pulse, but it is an upstroke pulse. So blood in the ventricle tries to eject but does not reach the aorta and moves backward. That is in severe MR. Coming to the contour, pulses bispherians. Now, this is very confusing words like dicrotic pulse or pulses bispherians. Okay, pulses bigemini. Pulses bispherians, that means in the systole itself, you get two pulses, which is seen in HOCM, severe AS, AR, AS, and severe AR. This is the percussion and tidal wave, which both have been seen in systole only, and best felt at radial pulse. So, what is the mechanism behind this? That is also the lateral pressure, which is important over here. So, it is a high stroke volume that has been injected. Okay. Now, the blood tries to move out. There is increase in the velocity. Now, AR is mostly seldom associated with the AS. It may be a mild AS. So, there is decrease in the lateral pressure in the aorta, which is seen in systole itself. Okay, which happens in mid systole. So that is important. That is depicted over here in pulses bispherians. Dicrotic pulse. There are two peaks, one in the systole, one in a diastole. So that is mostly dicrotic means peripheral resistance, right? So that is the dicrotic wave. So increase in the dicrotic wave, there is increase in the peripheral resistance. Whenever there is increase in the peripheral resistance, there is decrease in the cardiac output. That will be seen in left ventricular dysfunction or in case of failure. Pulses alternance, alternating pulse. Why is there alternating pulse? Because the stroke volume is not fixed. Okay, there is alternating pulse because the stroke volume is not fixed. This is in left ventricle failure. Okay, now this could be attributed to left ventricle failure. This could be attributed to there is premature depolarization in the left ventricle failure, and that is causing release of calcium. So calcium will cause the increase in the contractile force. So this pulses alternance is also checked with the BP cuff. Coming to pulses bigeminy. So there is a normal pulse with the VPC. Normal pulse with the VPC. This is the pulses bigeminy. So this is an irregular rhythm. After the VPC, we know even in the in another conditions wherein the VPC is found, there is much of the time which is remaining after the VPC. There is much of the time which is remaining for the heart to fill in the diastole period. So the next pulse will be of higher amplitude, like here. The next pulse is of higher amplitude. So after VPC, if the pulse volume increases, except for that of the HOCM, which is called as a broken box sign, wherein there is a dynamic obstruction, that is a SAM, systolic anterior motion abnormality, and there is decrease in the volume. So after that of each of the VPC, there would be increase in the pulse volume. That is attributed to increase in the diastolic filling because it gets time to fill. The heart gets time to fill. Pulses paradoxes. With the inspiration, normally there is this phenomenon of decreasing by the blood pressure by 10 mmHg, and but whenever there is exaggerated this exaggeration of normal phenomenon, this is pulses paradoxes. So what happens is there is negative intrathoracic pressure which is there. So while inspiration, so what happens? This is the transmitted to all the chambers. So all the chambers have decrease in the pressure during the inspiration, and there is this ventricular interdependency. This means this septum that is seen, the septum that is seen, that will go and stick to the left ventricle. Now what happens is left ventricle cannot eject much of the blood. So there is exaggerated right-sided filling. There will be decrease in the stroke volume and decrease in the cardiac output. So there will be decrease in the systolic blood pressure. So it is seen in much of the conditions like that of constrictor pericarditis, cardiac tamponade, pneumothorax, bilateral pleural effusion, pulmonary embolism, OSA, asthma, COPD. Okay. So here, even here, I have explained cardiac tamponade. The pericardium is filled with the fluid. The right ventricle volume is increased with the inspiration. The right ventricle compresses the left ventricle, and the left ventricle stroke volume decreases. There is decrease in systolic blood pressure. The constrictor pericarditis, there is this typical phenomenon wherein in the diastole, the one third, early one third of the diastole is not affected because there is this calcification that has occurred over here in the heart. This is a symmetrical calcification. So during the diastole, one third will be able to fill, but the rest will not be able to fill. So only the one third of the diastole is filling over here. The septum is pushed, and then again the left ventricle stroke volume has been decreased. That the COPD, there is also similar phenomenon of their lungs are hyperinflated, the vascular bed expands during the inspiration, the blood is pulled into the pulmonary circulation, there is decrease in the blood flow to the heart, decrease the cardiac output. Pulses paradoxes. So to see for the pulses paradoxes, we need to see with the BP curve like that of pulses alternance itself, and see for the systolic blood pressure during the inspiration and then systolic blood pressure during the expiration. And if it is more than 10 mmHg, then we will see to it as a pulses paradoxus, which is felt at the femoral artery. I hope you have gained a lot from this video, and you use this on practical basis on and daily basis on the patients, and study a lot more about the pulse. Thank you so much for watching.